Okay, good afternoon. I hope that people can hear me. Can they?
You should be good.
Yeah, okay. This is Dr. Kemener from Yukon Health Center. Let me see if I can move the slides. Can you give me control
You'll
over the
have to
slides?
ask me to because it's on my computer.
Oh, I need to also, I should ask you to say next slide, please, and so forth.
Yes.
Okay. Okay, everybody, sorry for the delay, but we're going to go through this in a coherent way. So I'm Dr. Kemener, as I mentioned. I'm a child and adolescent psychiatrist who specializes in high-risk behaviors, and particularly assessment and treatment of youth substance use, with special interest in depression and suicidality. And that will bring us to today's presentation. I also want to mention to you, I don't have this slide here, that we are running now a treatment study free of charge at the University of Connecticut for young people 14 to 21 with substance use disorders. And we are welcoming referrals. You can call my office number and/or email me, and then we will connect you with the right person and check for eligibility. We have highly experienced therapists that are working with us, and we have a lot of experience of more than 30 years of working with adolescents with substance use disorders. This is a psychosocial intervention of 10 sessions. Okay, and now to the presentation du jour. Next slide, please. I'd like to thank my collaborators. Next slide, please. And disclosures we need to do. So the studies that I will mention that I've conducted have been funded by the University of Connecticut and graciously by the Wood Foundation. And I've also been receiving royalties for professional books that you can find on the website of the American Psychiatric Association Publishing or on Amazon. Thank you. Next. Next slide, please. Okay, let's start with terminology because it's very important to be on the same page here in terms of understanding. What we usually call in general drug overdose is a very general term. Medical examiners like to use the term fatal drug intoxication because this is more specific, so it tells you that indeed there is a fatal outcome of intoxication by a psychoactive drug. People have different tolerance and thresholds for morbidity and mortality due to consumption of drugs, and that's why overdose is kind of personal. Fatal drug intoxication is more generic. When I'm using the term youth, I basically use an inclusive term of pre-adolescent 10, but probably more 13 to 25. Why 25? Because that's where and when the prefrontal cortex, an area that is responsible for inhibition and delays of gratification, supposedly matures. In terms of suicide, we need to address two main issues. One, there should be a clear intent to determine that this is a suicide, and also there need to be the available means to do so. Another two terms that people usually kind of mix, so that's why I'm kind of clarifying them. We usually talk about the cause of death. Is it an injury? Is it a certain disease? Is it some kind of a malignancy? But medical examiners use the term also of manner of death. So it depends on the circumstances, and it can be accidental. It can be intentional, and that's one of the issues I'm going to address today in terms of suicide intentionality. And it can be undetermined if they were not able at the medical examiner office to make a conclusive decision by using the scene of the event information, autopsy, and also analysis of body fluids. Next one, please. Okay, so we are here always in the midst of the chicken and the egg controversy. What came first? Let's say the substance abuse came before the psychopathology, or maybe the psychopathology came before. This is a very lovely, cute children's book. I also write children's books. I didn't try this one. That the chicken and the egg decided to stop arguing who came first, and decided to move on together, which would be nice if we're going to have this kumbaya around us in our country and in the rest of the world. Next one, please. So the situation is not good, and I'm going to make a couple of opinionated comments. One of my observations is that there is an inverse correlation between the progress in technology and mental health of our youth. What do I mean? Any kid would like to have iPhone 30 and Galaxy 500. On the other hand, as you can see, starting in the 1990s, the rate of depression has gone up consistently. That was the age of melancholy in the 1990s, and little did the late Professor Kellerman knew that he was a prophet, because in the 1990s, the probability of having depression was in a single digits. And as you can see, based on the last information we have to 22, I'm waiting to see it's at 23, it kept on growing quite tremendously among adolescents and among what we call emerging adults or young adults up to age 25. And as a matter of fact, right now, every fifth youngster in the United States may qualify for major depressive episode, which is not good. As you can see, qualifying or meeting the criteria for major depressive episode increases the likelihood of using substances at a significant level. Similarly, and there are going to be a few slides to show you, the rates of suicide from 2007 until now kept on creeping up constantly. So there is a question, what are we doing wrong? Or what are we not doing right? Or what don't we know that prevents us and inhibits us from making any kind of improvement? You know, there are all kind of helplines and intervention here, intervention there, but bottom line, in general, the numbers keep on creeping, and that's definitely an issue need to be decided. I'll mention a couple of ideas where we are supposed to go with this, but right now we are not doing well, and the rate of depression and suicidal behavior keep on creeping up. Next slide, please. So let's get to opioid misuse, because we're going to talk mainly about opioids and, of course, fentanyl, which is an opioid, but also address some other drugs that are, the use is rising and mortality associated with the use is going up. So United States is a highly populated country, probably around 340 million people. So any little problem affects many people, and we have very large samples. So you can see past year, that was 2023, almost 9 million people misuse heroin. And many people use or abuse prescription drugs. And the fentanyl misuse, also close to 1 million, and it still keep on climbing. So we are, and this is very conservative estimate, because as you know, this is an illegal activity. So we don't have the full picture, but the picture is pretty bad. Next one, please. Next slide. Thank you. Okay, so a couple of, can we go, okay, suicide in youth, kind of to let you know what is happening. So again, you can see that in the last 20 years, roughly speaking, there was an increase of more than 50% in suicide. And when I say suicide, it's a completed suicide, meaning mortality. For example, in numbers from 2021, if you want to break it down according to ethnicity and race, unfortunately, and it's been for many years, Native Americans have the highest rates, then followed by white people, and then Blacks, Latinos, and Asian are kind of in the same margin, which is single digits. Among older youth, aged 18 to 25, it's even higher. The rate is 18 per 100,000. The majority of adults and youth with suicidal behavior can be identified with having a pre-existing diagnosable psychiatric disorder, which make it very important, of course, to screen, assess, and diagnose. And also co-occurring substance use disorder and psychiatric disorders keep on increasing, and it also increased the likelihood of suicidal behavior that is associated anyway, either with substance use and or with any kind of psychopathology. Next one, please. Next slide. Thank you. So quickly, these are the opioids we are familiar with. And look at the bottom right, fentanyl, you already heard about it, but there's also more powerful aspects, if you will, or extensions, if you will, chemically, of fentanyl. One is carfentanil, which is even stronger. And most recently, we've been exposed to nitazines, which are a new kind of opioids that are 30 to 50 times more lethal than fentanyl. So if fentanyl is 30 to 50 times more lethal than heroin, you might imagine what's going to happen if nitazines will become more and more popular. So basically, we have a lot of mortal agents that are spreading around, and we already have seen several cases here in Connecticut based on information from the medical examiner's office. Next one, please. Okay, so fentanyl quickly, just to make sure that we are on the same page. It's a synthetic opioid pain medication, rapid onset, short duration, extremely potent and lethal, and got all kind of streets names. But bottom line, as you can see, there are different kind of analogs, including the carfentanil that I mentioned to you in the previous slide. Next one, please. So here it is. You know, the numbers are very small, but take them seriously because we are talking about young people, and nitazines are starting to be shown. And as you can see, they jumped into 10 cases in 2023. 2024 data, this is only a partial data. So probably the final number can be at least 10, if not more, and be waiting to see what's happening in 2025. So again, there's all kind of, we're playing cops and robbers, all kind of new analogs and new drugs that are getting in. And unfortunately, they cause morbidity and mortality, and we keep on chasing them. As you also can see, it includes the designer benzodiazepines. And I'll show you a slide later on, although it's not usually a problem in the Northeast, but stimulants, definitely methamphetamine and cocaine, are also collecting fatalities in a very alarming rate. Next one, please. So this is what it looks like. It's very sweet. It's very innocent. It's almost like in Alice in Wonderland, you know, eat me, drink me. Looks like antidepressants, and no wonder that these colors are so attractive, because it's part of the way to attract a customer, and particularly young one. Next one, please. Another example, it looks like marshmallows or Turkish delight, lovely colors, and people might even mistaken it to something sweet, and particularly young people. And I'll show you a heartbreaking slide about death between the age of 0 and 4 in the United States due to overdose, which, as you might understand, it's not because the kids get it, but because they are basically abused, whether intentionally or unintentionally, in a toxic environment by their parents. Next one, please. So if you remember, this is a little old, but there were some issues in New Haven almost a decade ago. People were attending a concert on the Green, and there were a lot of casualties, although nobody died, but the numbers of OD were significant, mainly due to K2, which is a synthetic cannabinoids, and that was really a messy situation. But these things can happen anytime. Yes. Unfortunately, again, using my idiosyncratic sense of humor, unfortunately, a lot of times parents in the summer take their kids, drop them off at the music venue, and unfortunately collect them at the emergency room because they've been intoxicated, overdosed, and that's a major issue, because it can cause morbidity and mortality. Another issue, it clogs emergency rooms that are needed for, other emergencies, such as, heart issues, stroke, and accidents. So definitely, this is an unwelcome trend, but it happens more often than we think. Next one, please. Okay, and this is the heartbreaking information that just was published most recently, as you can see. Look at these numbers of kids from age 0 to 4, and also kids who are a little bit older. But bottom line, we talk about close to 2,000 cases of fatal pediatric opioid poisoning. So we are not doing very well. And I'm not sure if I have a slide on it, but let me tell you, if people get excited, what is America better in compared to other countries? We are the worst in the world in terms of drug overdose fatalities. So the country that's doing the best is Portugal, where the rate is about 6 fatalities per million. If you move to the southern Mediterranean, which is Spain, Italy, France, Greece, it's in the teens per million. You move up to the British Isles, it is about between 30 to 50. So you see the numbers grow up very quickly, almost exponentially. But if you think this is bad, you move up to Scandinavia, it's between 50 and 70 per million. 50 and 70 fatalities. And you say, oh, how bad can it be? Well, cross the ocean, come to the United States. We are doing, on average, more than 300 fatalities per million. Connecticut is not doing very well. We are a state of about 3.6 million people, and we crossed the 1,000 when COVID started. The last year was a little better, but we need to see if this trend will continue. But nevertheless, the rate is about 340 to 350 per million. And this is pretty bad. So again, compare it to Portugal and to the southern Mediterranean countries and ask what's wrong with us. I'll give you a couple of explanations later. Next one, please. Okay, a couple of quick slides that we're going to move very quickly, basically showing you that the trend of death is going up. Next one, please. Again, going up. Again, let's stay here, yes. The other slide again shows you that opioids, especially synthetic ones, are rising faster than anything else. So this is a slide by one of my Dutch colleagues, Wim van den Brink, and that he looked at several years ago, what's the difference between the USA, Europe, and NAL, which is the Netherlands. As you can see, one of our major problems has always been prescription. We overprescribe, although now we have reined it to some level in all this pill mills industry. We have much higher rate of problematic opioid users. And the OD death you can see per 100,000, I was mentioning a million, is more than 30 versus 2 in Europe and less than 1 in the Netherlands. And proportional of fentanyl is pretty high here. I think they didn't have a lot of fentanyl in Europe, so it's question mark. And what about people who are on opioid replacement, such as the Root Foundation, methadone, buprenorphine? We've been doing much worse than other countries. It was about 13%, when in Europe it was close to 50, and in the Netherlands, a little bit above the average. So one of the answers, we need more treatment facilities. We need more professionals who are knowledgeable and experienced in working with opioid users. And we need to increase the awareness and the availability of these facilities, because this is what is going to save life. In general, opioid users who are in replacement treatment, such as on bup or methadone, are 3 times less likely to overdose. So that's a good enough indication and justification to have more treatment facilities. Next one, please. Next slide, please. Okay, let's go back to the waves. Okay, 3 waves. One more. Next one, please. Stop here. Okay. So actually, we are now at the 4th wave. It sounds like a science fiction story. So in the beginning, there was just issues with prescription opioids. Then wave 2 was the rise in heroin. Then wave 3 is a synthetics, such as fentanyl. And in addition to it, in the late 19 and 20, xylazine was added to it. Xylazine is another one of those veterinarian anesthetics and analgesics that people found that they can get high on. Now, wave 4, which doesn't affect us that much in the Northeast, is actually a combination of opioids, fentanyl alike, and stimulants such as meth and cocaine. They found specifically in the Southwest and Northwest that about 40% of the cases of people who use stimulants, the cause of death was stimulants alone. 60% it was in combination with opioids and benzos, but stimulants alone also are highly lethal. As I said, for some reason, for some kind of market economy, of the illegal market economy, we don't see much stimulants here, but we see more opioids than we see in other countries, in other states. And by the way, the rate is much higher here than other states. For example, I have a lot of experience with what's happening in Oklahoma and Nebraska, and their overdose rates are about half of what we have. So something is definitely different here. Okay, thank you. Next slide, please. So here it is, the 4th wave, as I mentioned to you. It's polysubstance use and stimulants, and also all kind of new age of benzodiazepines. So while we are struggling with what's happening, there are some people who are, these illegal drug entrepreneurs are working on all kind of new agents. So, and we keep on chasing them. Next one, please. Here is the information that I mentioned to you about stimulant fatal overdose. Again, it's not an issue we see in the Northeast, but it's definitely responsible for some major casualties. And again, break down ethnicity and race. It seemed that actually white people are less affected than blacks, Asian, and Native Americans. Although this keep on changing, it's this is a very flexible map in terms of drugs that come to town, and unfortunately, it's an equal opportunity offender, and a matter of, if you will, choice. I mean, what really attracts certain people to use certain drugs when there is some kind of a buffet. So we can definitely see some differences. Next one, please. Okay, let's move a little. Okay, next one. Several slides that I don't want to exhaust you completely. They're pretty depressing. Stop here. One of the points, let's get back to this one. Thank you. Yeah, let's stay here. What is really numbing and disturbing is, look at this. In Connecticut, the number of drug overdose fatalities is larger than motor vehicle collisions, homicides, and suicides. This is unbelievable, guys, because this is not something you would have expected, because a lot of people don't even know that there is drug overdose epidemic because they're not being hit personally. And, think about the three main causes of death among young people, which are in the Western world, which is number one, car crashes, number two, suicides, number three, homicides. And now you've got a new player. It's not so new, but it's some kind of the elephant in the room that we ignored, which is drug overdose. So all of those causes for death, of course, are preventable. But this relatively new player in the last 10 to 12 years, starting in 2012, things started to go up very quickly, is responsible for more death. So as you can see during this period, more than 1,400 people died due to drug use, and about 1,000 died from all other combined. Next one, please. Okay, and again, you will have access to the slideshow. You can see basically the continued increase. 2024, things stabilized. 2025, we are hoping for some reduction. But as you can see, if you look at 2012, when we had 357 cases, and by 2022, 2023, we were around 1,400. That's about four times more. So again, this is a terrible, terrible statistic. Next one, please. Okay, mortality by sex, it's higher among men, but definitely a lot of women are being affected. Next one, please. The question of intentional versus non-intentional also comes up, and I will show you a couple of slides. And also, this is kind of a breakdown in terms of racial ethnic issues. And as you can see, non-Hispanic blacks are use is growing up in the last 5 years. Although 10 years ago, people used to write that actually drug overdose opioids is a white man problem. And but right now it's everybody's problem pretty much. Next one. And this is by age. So as you can see, the main numbers are definitely going up with age, including, look at this increase over age 55. So it basically affects all age groups, and this is a major issue that we need to address. Next one, please. Okay, something from Connecticut. Again, this is a study conducted about 10 years ago, and it shows you, apropos the people who are pro-legalization of marijuana for recreational purposes, which I've always been against. it shows you that when teens use cannabis, the likelihood of using other drugs is increasing dramatically. And here you can see information about painkillers, heroin, and other drugs. So the political correctness of the left progressive is we don't like the term gateway drugs. Too bad, deal with this. Cannabis is a gateway drug. People don't start using heroin, cocaine, and fentanyl out of the blue. They go through alcohol, tobacco, cannabis, and because some segments of adolescents, it's not enough for them. They need more sensation seeking and a better high. So they move to these drugs that are definitely more lethal. I don't like the term light drugs and heavy drugs, but talking about the potential for morbidity and mortality of these drugs, it's pretty clear. It's different. Although people who say cannabis doesn't kill, even if you consume a pound, well, you get behind the wheel, like when you get behind the wheel when you DUI on alcohol, the rates of fatal crashes usually doubles. Next one, please. Next slide, please. So what are the markers or what's the information that can help you know who is more likely to develop opioid use? It's early age of initiation of any drug, any psychopathology, and also using opioids medically and non-medically. I won't get into discussion over pain management because it's beyond my expertise, but definitely people who are taking opioid for pain management need to be careful because if they might have some tendencies for abuse, the availability of pain medication may lead them into dependence and also might be available for other people at the household and around them, which increases the cycle of affected individuals. And by the way, even having alcohol use disorder increases the chances for rapid opiate use disorder. So, when we use the term cross addiction, one thing leads to another. Next one, please. And again, there are several slides here about cannabis. And again, don't do it at home and make sure that adolescents are under the impression that if it's legal and there's also medical cannabis, it's okay to use. The answer is no. And basically, the use of cannabis increases the likelihood of using other drugs, including opioids. Next one, please. We have some information here also from Canada. And again, they have similar problems to what we have. Canada officially approved cannabis for recreational purposes in 2018, and until now, summaries of the 5-year experiment, there's no good news, particularly not for adolescents. Next one, please. Again, here's some information about fentanyl, which is a terrible, deadly drug, and it will lead us to the study that I've conducted under the Ruth Foundation funding. These are studies that conducted at McLean Hospital in Belmont, which is affiliated with Harvard, and they looked at survivors of drug OD and find that basically the desire to die and the intention to die were quite high and overlapping. So desire to die means, well, drug users of opioids know the potential lethality, but somebody says, well, it's a nice day, I want to get high. If this is going to cause me morbidity or mortality, so be it. As compared to having intention to die, which is suicidal intentionality, that people look at different potential means for lethal suicide, and one of the choices is overdose. So it's very important to understand the issue of suicidal intentionality when we conduct assessment of our patients. This study was done with adults. The study I conducted at Root was with younger people engaged in methadone maintenance clinics up to age 25, meaning 25.11 months. Next one, please. So we talk about suicidal motivation. Can we go to the previous one, please? No, go backward, please. One more. Thank you. So the idea is to look at suicidal intentionality. So again, I'm showing you this slide again, so you kind of be able to memorize it. Okay, now let's move to the next slide. Quickly go over what is a medical examiner job. And the medical examiner of Connecticut is in his office, his building, actually, it's next to mine at the Farmington campus. And this is an agency that is required and mandated to investigate sudden, unexpected, or violent death. Next one, please. And by the way, all the information about the Chief Medical Examiner Office is in the public domain. You can go to the website and you will be exposed to data you wouldn't have thought it would be in the public domain, but it will provide you with a lot of information. And as you can see, it can be accidents, suicides, homicide, poisoning, diseases with potential public health threats, as we had, the COVID epidemic, but anything else from myocardial infarction, brain strokes, and all kind of other issues. Next one, please. But my first two studies were actually based on reviews death certificates at the medical examiner's office in order to find out how many young people died due to drug overdose. And by the way, they've been doing a very good work because the percentage of undetermined cases is relatively small. So that means that they can be conclusive in their decisions. Next one, please. So again, another important statement: if any injury caused or contributed to the death, only medical examiner can certify that death. So the medical examiner office staff are the only one who can make this determination. Next one, please. There are all kinds of complexities and limitations. One of them, of course, during COVID, because of the high number of people who perished, definitely the profession of being a pathologist, a medical examiner, is, we have a deficiency, and it was, I think, considered that we need between 500 to 700 more. Second issue is politics, and most people are not aware of it. Well, there are states, particularly further south you go, that the medical examiner is not an MD or a pathologist, a professional. It's actually a politically assigned position. And in the office of this person, the medical examiner who doesn't have a medical degree, they have pathologists and other professionals working with them. Why is it disturbing? Because we found out, there was a paper about it that blew my mind, that the rates of reports of death, particularly intentional death, were half in those southern states, which means that people can lean on this person who was picked up and nominated politically and say, well, we don't want you to report that my son or daughter or loved one committed suicide, or that it was really a homicide. So there's some room for, foul game, which is unfortunate because it's not just in terms of statistics, it's also in terms of how do you address all kinds of trends of lethality. So that's really fascinating that there is such a difference between the states, and it was news to me. It sounds like it's like another one of those secrets that we all should be aware of, but it's not well known. Next one, please. In Connecticut, by the way, we have professionals. It's not a political position. Okay, so we have several slides here that look at two studies that I conducted. One is looking at death certificates from 2016 to 18, the other one 2019 to 21. And unfortunately, the rates of death among young people increased, and also the rate due to fentanyl increased. And we even have several cases of kids under the age of 16 that, of course, it was accidental with those kids, but one was a kid that was actually living in a house that was quite toxic in terms of drug availability. Another one was a kid that somebody told him, why don't you use this, use that? And I think there is a campaign that it's very important to bring the attention of kids because, kids usually have short attention span, that this is the pill that can kill. If you don't know what you're using, and it doesn't matter what people tell you that it is, don't use it because it might kill you. Because we had several cases of people who just took medications because Ritalin, I thought it was Ritalin, to study for exams, and basically it was laced or with fentanyl, or it was a counterfeit. So we actually have three groups of potential victims. The first one is those who are known substance users who are familiar with the dangers, but they use it regardless. Second one are people that have other pathologies such as depression, PTSD, and so on and so forth. And they're not always aware of it, but they have a high likelihood of using drugs. And the third one are what you call the innocent bystander. These are the people who don't have a history of psychopathology or substance use, but they've been coaxed by their friends and whatever. Let's use this, let's use that, let's party, or they study to an exam and they become a casualty. So especially the third group is that we need to mention to them, if you don't know what you're taking, because it's not FDA provided and you didn't get it personally at a pharmacy as a prescription, don't take it because it might kill you. Next one. Okay, let's kind of move on. I will give you kind of the synopsis of these findings. Next one, please. So what we have found in our study is also something very similar. Well, it's not similar because we conduct our study in method of maintenance, but here you can see what I mentioned before, that suicide risk strongly elevated when people are not in treatment. So it's extremely important to provide treatment. The second issue, next slide, please, is that we have found in a relatively not a very large study that there were drug overdose experiences by the people in the study, and these are people up to age 26, as I mentioned, 25.11 months, that there were more than a single case of drug overdose. Now, one of the dangers of drug overdose for survivors that I'm not sure that everybody is aware is it can cause permanent cognitive and brain damage. Why? Because opioids take effect on the respiratory, on the breathing center in the medulla oblongata. So it may cause to hypoxia. And this is very similar to when people have myocardial infarction because there's not enough oxygenated blood that comes to the, that feeds or nurture the muscle of the heart, and then areas start to get infarcted because they don't get oxygen. Similar results can happen to survivors of resuscitation or, those who get naloxone, for example, So naloxone is not the end. Naloxone is just a mean to keep these people alive, but there are, and there, potential consequences, including hypoxia, and it affects the cognitive ability, and it raises the issue whether they are in in getting in a worse and worse shape to make decisions in order to help us preserve them and keep them alive because of the multiple episodes. And that will get you later to just wrote a commentary that has been not published yet, but accepted for publication in a peer-reviewed journal, where I'm addressing the issue of civil commitment, where we need actually at least have the discussion about the balance between, if you will, protecting people from hurting themselves versus maintaining their personal autonomy. Said, I am allowed to do what I want because I'm a grown-up, and if I want to die, I can kill myself. From my perspective, the short of it, and again, first of all, I want to see the discussion. I haven't seen any discussion anywhere about it, the pros and cons. This is very similar to a referral to the emergency room of a person who's suicidal, and people don't really argue about it, and the decision is being made in the emergency room whether to admit them against their will or keep them just for observation and see if the suicidality will, it usually waxes and wanes, or, they will be able to get treatment somewhere else. So this is definitely an issue that we need to address. This is just a list of the instruments that we used, and I think that, and again, I'm hoping we'll be able to conduct additional study. I'm involved in a study actually in Appalachia, where there's the term death of despair, where you have people usually over age 40 that lost their jobs, and it's a highly toxic area in terms of drug use and suicide. And I'd like to compare the young people, similarly to what we did at the Root Foundation, to older people. And I'm hoping maybe some point, if we get the funding, we'll be able to do something similar in Connecticut. Next one, please. Next one. Next one. Don't want to bother you with the numbers. And as you can see, some information about the suicide attempts. Everything was significant. And the correlation with suicidal potential was number of days using opioids in the last 30 days, whether people think that using the drug is called an overdose, and number of lifetime previous suicide attempts. Next one, please. Well, I think we can stop here because this is some kind of extra slides that are not totally related to what I'm talking about when I talk about impulsive behavior versus the compulsivity of using drugs. It takes us actually to another phase. So I would like to stop here and maybe take some questions or comments. Thank you. Heather, I think you're going to take the lead, or Darcy, or one of the Root Foundation leaders.
Yes, we will take the lead from here. Any questions, guys? Just remember that it's all in the chat. You can raise your hand if you do have a question that you feel is more lengthy and you would like to be brought online, then just let me know, raise your hand, and I can do that for you. Otherwise, just send it through the chat. Thank you. I see your hand, Caitlin. Let me get to you. Hold on just a moment. You're all set, Caitlin. Feel free.
Thank you so much, Darcy. I just wanted to say thank you so much for the presentation today. I think it was really helpful and informative. And I also just wanted to note, Darcy, that I think the chat is turned off. So I don't know if people are trying to chat and they might not be able to.
It's the Q&A. I am so sorry. You're right. Any questions for Dr. Kaminer?
I want to warn you because I see that there are some messages, somebody want to chat with you, and it doesn't look kosher. So be aware that, we might get invaded or are being invaded. So kind of
You just
stay
froze.
stay put only on this specific platform.
I don't think we're getting any questions any questions.
I see only one chat, but this is very suspicious. So I'm not gonna.
Yeah, I'm not seeing anything. I don't have any chats at all.
How many people are we having with us?
We have 43.
Okay, so I'm sure that at least one of them would like to ask a question. Push come to shove, if we have some technical issues, maybe people should address questions to you, and you can kind of collect them, summarize them, and send it to me by email. I won't be able to respond right away, but I will definitely try to get to it within 7 to 10 days.
Amanda did send, I'm sorry, Doug, that's a wonderful idea, and we definitely will do that.
Yeah.
Amanda did send a question, or she said no question, but just wanted to reiterate, thank you for the information. It was definitely eye-opening. Thank you so much for your time.
Sure. And again, I'm hoping that we will have more opportunities to study this phenomenon, and because we have access to a lot of young patients, that your staff is doing a tremendous job working with them. We were able to be in 4 sites, and the leaders as well as the clinical staff have been extremely helpful. So I would like really to congratulate you for the dedicated work that you do, and for your openness to study what's going on there, because especially suicide is a major
You
concern.
keep going out, Dr. Kaminer.
Sorry?
Your sound keeps going out. I do have 2 questions for you, by the way.
Okay, go ahead, please.
From Kayla, with acknowledging the brain impairment with overdosing, how should clinical treatment be adjusted to support those deficits?
Okay, you mean the fact that there is some morbidity among survivors that have brain damage or cognitive dysfunction? That's a question?
Yes.
Well, we need to add probably to the arsenal some kind of neuropsychological testing. Because again, we don't want to patronize people. It's very sensitive, and the stigma, and people don't want to be in treatment, but you need to convince them that the use and the overdose has not kept them healthier than before. Actually, it might have compromised them, and it is important to understand what is going on after the episode of drug overdose. So I think it's important to add neuropsychological testing and assessments for any survivor.
Did that answer your question, Kayla? While she's responding to that, we'll go on to Dara, who says, can you please explain what the program in Appalachia is and what that would look like in Connecticut?
Well, it's actually it's a grant application because the situation there is pretty bad, and all this issue of death of despair, which also, by the way, affect the children of those people, and it probably could be part of the explanation to why we are not doing very well nationwide. The numbers are going up because there are different kind of populations that are not doing well. And I'll give you an example that in most part of the United States, life expectancy have been slowly going up, which is good news. But they found out, a couple of economists, by the way, from Cornell in 2015, that in certain areas that you can call Appalachia, life expectancy has gone down, particularly for males. And this was really like an anomaly. And then they defined this term of death of despair and what is associated with it. Now think about it, how sad it is that if we have, roughly speaking, 100,000 people who die every year in the United States from drug overdose, they have family around them, and they also have children. And it affects the children as well in terms of their mental health. So it's like, like in the biblical term, the sins of the fathers, so to speak. I don't want to call it sin, but you understand this becomes a transgenerational morbidity, that these kids already start their life with a major handicap. And it's extremely important, as you know from development, that early life experiences are detrimental. For example, being emotionally abused at an early age is even more harmful than physically abused. And those kids later on tend to be victimized and bullied. I've been many, many years in this field, I don't remember, let's say 10 or 15 years ago, I've never seen 10 to 14 years old girls who are suicidal. But given the fact also that we have social media and accessibility to a lot of gadget apps and so forth, and people can get anonymous, I don't want to call it causation, but A leads to B, but there's definitely some association. And that's why I made this claim that there is an inverse correlation between progress in technology and mental health and mental health quality of health. And you probably heard that last week, Australia banned the use of social media under the age of 16. How they're going to enforce it, I don't know, but it's a move in the right direction, recognizing that social media, yes, of course, it has some positive sides, but it has some major negative sides, and it's addictive. And basically, people in chat, all these companies that develop AI and chat boxes prey on our kids, and they suck from them data and mental health. And I know you have this event on January 13. Unfortunately, I can't be there, but media effect on young people. But this is getting into a crisis mode already, including suicide cases. Another issue, several years ago, it started in France. The recommendation was not to expose babies under 2 to any screens. And now the American Pediatric Association and the American Academy of Children's Psychiatry recommends the same. I think it should be even extended to 3, 4, or 5. But again, we play cops and robbers. Technology runs forward the same way that legalization of cannabis runs forward until we find the evidence it's not doing well. But hey, we are a society based on that consumption is the most important issue, and you need to give the people what they want. And many times what you give the people, what they want is not necessarily what they need, and it causes them harm. And I can go on and on and on. I wrote a commentary called, Addiction, a Disease of Consumption. It needs to start with consumption. So this is kind of where we are right now.
Thank you, Dr. Kaminer. Just one more comment. Thank you for the presentation. Very interesting and alarming data. I think that's all we have.
Okay, thank you very much. And again, you know where to find me if there are other questions or other comments, or, would definitely like to continue my relationship with the Root Foundation and providing information. And you guys are doing great work. Keep on doing it, and happy holidays.